So now let's discuss regarding post-streptococcal glomerulonephritis, which is abbreviated as PSGN. Okay, post-streptococcal glomerulonephritis, PSGN. So what is this post-streptococcal glomerulonephritis? So the term itself implies maybe after some streptococcal infection there occurs some glomerulonephritis. Okay, all right. Now this particular term PSGN is a bit outdated now. Okay, so why is this term outdated? Let's find out. The terminology that is often used now is that of a infection related glomerulonephritis. Infection related glomerulonephritis, that is IRGN. Okay, IRGN. So why such a change of preference for the name is because previously it was thought that you get glomerulonephritis only after a streptococcal infection. Okay, so you have a streptococcal infection and somebody developing a glomerulonephritis. So the entity itself was thought to be only due to streptococci. But now we understand that it is not just streptococci. Other organisms like Staph aureus can also cause a glomerulonephritis. So the better term that is preferred now is infection related glomerulonephritis. All right. Now, when we discuss regarding IRGN, it is always easy to understand from the viewpoint of the organism. Okay, that means you have two subgroups of IRGN predominantly. Okay, this is just an artificial classification for the ease of understanding. You can subgroup into two. Okay, so one is an infection related glomerulonephritis that is seen in case of children. Okay, that is seen in case of children of age group of around 2 to 14 years. Okay, and also you have the adults. Okay, where usually above 60 years. Okay, so these two are the groups which can develop a IRGN, infection related glomerulonephritis. Now why did I say that from the point of view of the organism is because in these two groups the causative organism for the glomerulonephritis, okay, is different. In case of children, the glomerulonephritis is usually associated with group A beta hemolytic streptococcal infection, group A beta hemolytic streptococcal infection. Okay, whereas in case of your adults, it is usually Staph aureus, and most often MRSA that would actually cause the IRGN, infection related glomerulonephritis. Now let's try to understand this a bit more. When you take into account the first group, that is children having an infection related glomerulonephritis, so this is mainly because of streptococci, which means this is the actual PSGN group, okay, post streptococcal glomerulonephritis group. So my first question to you is, I'm sure you would have learned in your microbiology lessons also regarding the streptococci. So let me ask you one question. Does all strains of streptococci cause a post streptococcal glomerulonephritis? Answer is no. You have certain nephrogenic strains. Okay, you have certain nephrogenic strains of group A beta hemolytic streptococci which are associated with the infection related glomerulonephritis. And talking about these nephrogenic strains, so it is clear that there will be initially some infection. Okay, and after this infection there is some immune response. And because of the immune response, there is formation of immune complexes, and these immune complexes are getting deposited in your kidney. Okay, so that is basically what happens, right? So The nephrogenic strains of group A beta hemolytic streptococci, let's try to understand what is the antigen that triggers the immune response. So in this organism, there should be some antigen that should trigger the immune response. So the antigen, the major antigen that triggers the immune response is the streptococcal pyrogenic exotoxin B, okay, or you can say it SPEB, streptococcal pyrogenic exotoxin B. This is the main antigen that incites an immune response and subsequently leads on to the formation of immune complexes. Okay, so this is actually since it is an immune complex mediated, this is actually a type 3 hypersensitivity. So though I told you this is predominantly because of the SPEB antigen, another antigen that is also implicated, okay, in the pathogenesis of a infection, that is your post-streptococcal glomerulonephritis, is referred to as the nephritis associated plasmin receptor, which is NAPLR, okay, that is nephritis associated plasmin receptor. So these two are the antigens of the streptococci that would initiate the immune response. So that is also clear. Now next, see, when you have a streptococcal infection, you know that streptococci can cause various infections. So what is the infection that would often cause a glomerulonephritis as a sequelae? So it's predominantly the skin infections. You know that streptococci can cause impetigo, okay, as well as it can cause pharyngitis. So the strains which are associated with the skin infections, you have certain strains associated with the streptococcal skin infections, and you have certain nephrogenic strains associated with the pharyngitis. Both these can actually trigger glomerulonephritis. It doesn't mean that each and everyone who is developing a impetigo or maybe a pharyngitis because of streptococci is going to develop glomerulonephritis. No, but still this is actually the one that triggers it, okay. So skin infections as well as pharyngitis. Now one important point to note is that in case of your skin infections, okay, the streptococcal skin infections, the usual lag period, that is after the infection to the development of glomerulonephritis. Remember, it is a post-streptococcal glomerulonephritis. So there is an infection and there should be a lag period. So in case of your skin infections, your lag period will be around 2 to 6 weeks. So it would take a period of around 2 to 6 weeks from the streptococcal skin infection to the development of glomerulonephritis. Whereas when it comes to pharyngitis, this is about 1 to 3 weeks. Okay, very, very important. All right, so that is, I hope that is clear. Now coming back to the two groups, okay, IRGN, children and adults. In adults, please understand that it is usually above 60 years. You may occasionally get it in the 5th decade or maybe the 6th decade, okay. So, but usually above 60 years, and often it is associated with an MRSA infection. So whenever you talk of MRSA infection, it is likely that the individual is probably having some other immunocompromised condition like a diabetes. So the trigger might be, the patient might be one with diabetes, and because of that, chronic diabetes, uncontrolled diabetes might have made him a bit immunocompromised. So that would predispose to MRSA infections, maybe some skin infections, cellulitis. So that infection can trigger as a trigger for the development of glomerulonephritis. Okay. So I hope you are clear with the properties of the organisms in these two groups and how do they actually cause this. Okay, so something is very clear that this, whatever it be, whether it be in children or in adults, it is going to be a type 3 hypersensitivity. Okay, very clear. Now what happens is that, see, there has been formation of immune complexes and these immune complexes would actually go to the kidney. Okay, now if you ask me what impact does this have, okay, that is about the pathology, what impact does this immune complexes have is that, see, this can actually cause acute endocapillary glomerulonephritis. Acute endocapillary glomerulonephritis. So it is very clear that the capillaries are definitely involved. But remember, the pathology is not restricted to the capillaries. What happens is that in case of your infection related glomerulonephritis, you will have certain important pathologic changes that are happening. One is the endocapillary proliferation. So there is an increased the proliferation inside the capillaries itself, endocapillary proliferation. Plus you can have other features like mesangial proliferation. So both endocapillary as well as mesangial proliferation you can have associated with this. And then you will have neutrophil infiltration. Okay, so the inflammatory cells like neutrophils, okay, neutrophil infiltration will also be there. Okay, neutrophil infiltration. And also you will see that the patient, the kidney also develops certain deposits, okay, certain immune complex deposits in the subepithelial region. Okay, subepithelial deposits. Okay, so these are the changes that can happen. That is, you will have a large glomeruli, endocapillary proliferation, mesangial proliferation, neutrophil infiltrates and subepithelial deposits. These are the changes that would happen. Do you want to see a simple diagram? Yes, we'll take it from Harrison itself, a simple diagram to show the actual changes that are happening. Just see this. First of all, you have a look at the subendothelial deposits are there. Okay, you have these subendothelial deposits. Yes. And you are seeing the mesangial deposits. Yes, mesangial deposits, and along with these deposits there occurs proliferative changes also, endocapillary proliferation, mesangial proliferation. And are you able to see something written as humps? Okay, humps. So humps are nothing but the immune complex deposits that would actually happen in the subepithelial region. So the subepithelial region would actually harbor immune complex deposits. Okay, and it is having the appearance of a camel hump. Okay, so it is referred to as humps. And you can also see, as I said, neutrophil infiltration also. So these are the changes that happens in your kidney in case of an infection related glomerulonephritis. I hope it is clear. Okay, all right. So having understood that, let's try to understand the clinical features. Clinical features of infection related glomerulonephritis. So here again, the clinical presentation in case of the children as well as the adults would be slightly different. Okay, so I'm sure from what you have learned in pediatrics, you might be well versed with the childhood presentation. See, anyway, one thing is very obvious. This is the post-streptococcal glomerulonephritis. If I am asked to just comment in one sentence, I would say about the clinical presentation, you know that it would present with a acute nephritis. Okay, it would present with acute nephritis. Okay, so it is a nephritic presentation that occurs in case of your children. And see, when you talk of a nephritic presentation, you know that we have already discussed this in the module on the clinical presentations of glomerular disorders. If you have not watched that, please go back and watch the nephritic presentation, where I have clearly told you the patient may have hematuria, may have oliguria, okay, and yes, you can have edema as well, but not to the tune that is seen in case of nephrotic syndrome. And you may have urine might show proteinuria as well. Again, proteinuria also not so severe as in case of nephrotic syndrome. The blood pressure may be high, okay, and there might be intravascular fluid overload as well. So patient may develop complications like acute LVF because of the fluid overload, increase in the preload. There can be a fluid overload and subsequent acute LVF, left ventricular failure. And similarly, because the blood pressure is high, there is hypertension, you can develop hypertension related complications. But remember, the usual presentation is as acute nephritis, but may develop complications like acute LVF, you may develop a hypertensive encephalopathy, and rarely may proceed to RPGN, rapidly progressive glomerulonephritis. So clinical presentation with acute nephritis rarely may have a complication, okay. So that is how the childhood presentation of a post-streptococcal glomerulonephritis occurs, okay. Now when it comes to adults, please understand that it is the childhood presentation is relatively one with very good prognosis, okay. Complications are seen in only a very small subset, whereas the adult form is not that benign, okay. I am not saying that all cases are very severe, but it is not that benign as the childhood presentation. Here there is an increase. Yes, you can have a nephritic presentation. Some individuals may have a nephrotic presentation or maybe a mixed presentation. But the issue here is that there is a higher chance of developing a rapidly progressive glomerulonephritis. See, even your childhood may develop RPGN, but that is very rare. Here the probability of going for a rapidly progressive glomerulonephritis is more. That is what you have got to understand. Okay, that is very clear. Alright, so this is adult IRGN is not a disease that you ideally would like to have. Okay, alright. Now regarding the, after having understood the clinical presentation, let's see the investigations. So investigations. So yes, you might have, say, a child having developed a streptococcal infection, maybe a pharyngitis 3 weeks back, now presenting with a cola colored urine, because often in the history they might give you this term, okay, cola colored urine, okay, cola colored urine. So, and then when you talk about the investigation in case of a post-streptococcal glomerulonephritis, so in children, you will notice that the serum level, because see, it is an immune complex mediated disease, and you will see that the serum level of your complement, serum C3 is actually low, okay, your serum C3 is low. But remember that it is not like this is one glomerulonephritis that is just going to progress with a low C3. This is actually a transient decrease in C3. After a particular period, maybe in say 1 to 2 months, usually 2 months period, the C3 would actually normalize, because I told you 90 to 95% cases of a post-streptococcal glomerulonephritis has a very good outcome. So remember that your serum C3 levels will be low. And also, since it is related to a streptococcal infection, you will also notice that the anti-DNase B, okay, anti-DNase B levels, that would be elevated, okay. Anti-DNase B levels would be elevated in as much as 70% of cases. And what about the ASO titer? The ASO titer is also likely to be elevated, but it is again not very specific and not clinically much useful, okay. So it is not something that is diagnosed per se by ASO titer. It is only in about 30% cases, 30, okay. In about 30% cases, you might have a rise in your ASO titer, but again, this is not clinically relevant, okay. Is not clinically relevant. So if you have to go for a particular test, it has to be in the, when you compare anti-DNase-B and ASO titer, it has to be anti-DNase-B and not ASO titer. Okay, so that also you have got to be clear. Now please understand that what about the utility for a biopsy? Do you think this is one disease that is going to be diagnosed by biopsy in all cases? See, all in all, this is a clinical diagnosis. Clinical means based on the presentation and maybe the low complement levels. So that is how you diagnose infection, the post-streptococcal glomerulonephritis. So biopsy is generally not used in infection post-streptococcal glomerulonephritis. So what you do is that you will actually treat the patient, and only if once the patient comes back in the follow-up visit, okay, because I told you serum C3 would normalize by 2 months. It would normalize by 2 months. Now what if when the patient presents to you after 2 months, he comes for a follow-up, even then if the C3 level is high, then you have to rethink your diagnosis. Okay, so then you might consider a biopsy, but otherwise there is no role for biopsy in case of a post-streptococcal glomerulonephritis. And in case of your adults also, see, it is having a RPGN presentation, so it's a rapid, again let me remind you one thing, it doesn't mean that each and everyone will go for an RPGN, but the probability of developing RPGN is more, so more aggressive course will be there. So sometimes, in case of a diagnostic dilemma, you might have to go for a renal biopsy in the adult cases, okay, because sometimes there might not be an obvious history of an infection. Like infection means, say a sore throat, we know that it is often associated with a cellulitis or some other infections by MRSA. So sometimes you would have some sort of a diagnostic dilemma whether in fact this is an infection related glomerulonephritis. So in that cases, sometimes biopsy may be required. Okay, so that is how you will evaluate. And suppose if at all you go for the biopsy, okay, suppose you are going ahead with the biopsy, what are the findings that you are going to see in your light microscope, in your immunofluorescence and electron microscope? Let's actually see that. First of all, let's see the light microscopy findings. Now light microscopy findings, I will just show you. I'll show you a comparative pictures for better understanding. This is actually a normal glomerulus, and this is actually a glomerulus of someone who had a infection related glomerulonephritis. Okay, and you see here something that is very obvious is, one is, you tell me whether you agree with me or not with each point that I am saying. The glomeruli will be large in case of your IRGN, okay. So the larger glomeruli, okay. So there is an enlargement of the glomerulus. And will you agree with me when I say that conclusively the cellularity is increased in IRGN? You agree with me or not? You can clearly see, okay. The cellularity is very much increased. So there is a increased cellularity, where all there is a increased cellularity in the endocapillary region, that is an endocapillary proliferation is there, as well as you have a mesangial proliferation is also there. Okay, so endocapillary and mesangial proliferation is there. So large glomeruli, increased cellularity in the endocapillary and mesangial layer, that is very, very clear in case of a light microscope. Yes, agree with me? All right. So light microscopy findings, that is very important. I'll just again, this is again another light microscopy finding. You see there are small arrows, you are seeing various arrows. Can somebody tell me who is a pathology expert? Okay, what exactly is this arrow pointing to? The arrow is actually pointing to neutrophils. You remember I told you, along with the endocapillary proliferation and the mesangial proliferation, you will have neutrophilic infiltration. So all these arrows are actually pointing to the neutrophils. Okay, this is actually a high power view for better visualization, okay, which cannot be appreciated in the low power view. So here you can see that there are lots of neutrophils, okay, it is studded with neutrophils. So this is the neutrophil infiltration. Neutrophil infiltration that you have in IRGN, okay, infection related glomerulonephritis, neutrophil infiltration. So I hope you are clear regarding the light microscopy findings in case of IRGN. Yes, all right. Now coming to immunofluorescence. Immunofluorescence in case of infection related glomerulonephritis can have two important patterns, okay, two patterns mainly, so which is likely to be asked in your exam. One pattern that you see as A is referred to as the starry sky pattern, okay, starry sky pattern, and the other pattern is referred to as the garland pattern. So let me tell you that in case of a infection related glomerulonephritis, in case of immunofluorescence, what happens is that you will have deposits of IgG and C3, okay, IgG and C3 deposits. So this IgG and C3 deposits this deposition can either happen in a diffuse granular manner, which is called a starry sky pattern, or it can have in the form of slightly dense deposits that is referred to as a garland pattern, okay. So you have got to memorize these 2 points, starry sky pattern as well as garland pattern, on the immunofluorescence finding in case of infection related glomerulonephritis. So some individuals may have starry sky pattern, some may have garland pattern. In general, we say that the childhood age group, okay, the post-streptococcal glomerulonephritis is likely to have the starry sky pattern, and garland pattern is more towards the adult presentation, okay. So immunofluorescence is also clear. Coming to the electron microscopy, you remember when I showed you the initial schematic diagram from Harrison, I told you that there occurs subepithelial deposits as well. You remember? And what was the name I mentioned? Subepithelial humps, okay? Subepithelial humps like a camel hump. So the electron microscopy finding that you will look for in case of your post-streptococcal glomerulonephritis is that, or the infection related glomerulonephritis is that, you will look for all these humps. Are you able to see certain humps out here? Yes. So this is the subepithelial electron dense humps. Okay, that is what you will see in case of infection related glomerulonephritis electron microscopy. Very clear. So these are the biopsy findings. Okay, these are the biopsy findings. You have got to be very thorough with this. Okay, so I hope I am very clear. All right, Pakka. Now let's move on to the treatment aspect. How are you going to treat this patient? See, often it is an infection related glomerulonephritis. So remember, most of the time in case of children, almost 90 to 95%. So that is a childhood IRGN will be having a good prognosis. Correct? Will be having a good prognosis, and it is almost in 90 to 95%. 90 to 95% will be having a good prognosis. Okay, so that you know what you have got to do is that you have got to just manage the glomerulonephritis part, where you have got to have a conservative management that you give for any nephritic presentation. Okay, you have got to have adequate salt restriction, okay, salt and fluid restriction. You have got to have BP control. Okay, you have got to periodically check your BP. You do not want the BP to shoot up, and you have got to serially monitor the creatinine. Okay, and in most cases, you know, patient would improve. Now, if you ask me, is there any role for antibiotics? Well, it is actually very controversial whether or not antibiotics is required. So if you see here, Harrison actually mentions that you can give the antibiotics. So, but you will see that other nephrology textbooks also there is some difference. But generally we say that See, you can give antibiotics if the infection is persistent. Because if you see, suppose if somebody develops a pharyngitis and subsequent post-streptococcal glomerulonephritis, see, it is usually after a gap of 1 to 3 weeks. So sometimes, if it is developing after 1 week, at that time, he might be having some pharyngitis component. So in that case, you can go for antibiotics. Okay. So otherwise, if the infection has been cleared, there is no infection, then many of the textbooks they say that okay, there is no need for a antibiotic treatment there. Okay, so that is why I said it is a bit controversial. Now even if you give antibiotics, you are going to give a single shot of a benzathine penicillin. Okay, a single shot of a benzathine penicillin, that is what you give. But remember, it is always controversial. Mostly preferred when there is an active infection. Okay, that is what you give. Now what about the role for steroids? What about the role for steroids? Steroids are also having no role in case of your post-streptococcal glomerulonephritis, no role in children. So it's predominantly the salt and fluid restriction and BP control that you have got to do in case of infection related glomerulonephritis. And please understand that this is relatively an acute presentation. And also this is not something that goes for a chronicity unless you have a RPGN developing in that patient. Otherwise, it is relatively a good disease which can be easily managed. Okay, all right. But when it comes to the adult presentation, so in such adults, I told you, you can have either a nephritic presentation or maybe an RPGN. So the role of steroids, there is a point of view that sometimes in case of adults who are having RPGN, you can try steroids. Okay, so it may be tried in case of adults, but otherwise for children there is not much role, and for adults only if again it goes for a rapidly progressive course will you try steroids. The other presentation of a classical nephritic presentation, you will not go for any steroids. Okay, so that is how you are going to treat infection related glomerulonephritis, whether it be children or in case of adults. So you have got to keep that in mind. So we have understood this entity of infection related glomerulonephritis. See, I gave the name as a post-streptococcal glomerulonephritis because see, even now that is a term that is more commonly used. But please understand that in your exam sometimes an examiner might put forward a question with the infection related glomerulonephritis. So there is no matters of any confusion. Okay, so this is a very important area or a topic I would say because it is common also. Okay, so learn regarding this entity, what actually happens in the kidney and how does it clinically manifest, the childhood presentation, the adult presentation, and subsequently how it is managed. Okay, all right.